Now, I'd like to anticipate the presentation by Professor Andrea Schlegel. She has an emergency case that is going to happen in a very short period of time. She will talk about the impact of donor and graft quality on cancer recurrence after liver transplantation. I think she is the best qualified worldwide in order to talk about graft quality and impact on postoperative outcome, in particular, I will say, in a cellular carcinoma patient. Andrea, are you connected?
Yes, Umberto, thank you. I hope you can hear
Please.
me.
Sure, perfectly.
And thanks for the invitation. Great topic. And I couldn't agree more. We could take and talk a week or month or year. And there was a great link because we talked a little bit already about graft risk, mortality, and preservation and how that impacts. And thanks for allowing me to change the layout. I have a disclosure. I consult with Bridge to Life sometimes, not so often. I more support the clinical sites. So I would like to look a little bit into the mechanism, why and how do grafts contribute to recurrence after transplant, the risk factors, of course, of donor and graft. And there's not so much out there. I also try to look a little bit into why we have extrahepatic recurrence, and we need to do some work there for sure. There's also, of course, operative risk factors. Paolo already said or spoke a little about transfusions. And then I will share a little bit the role of machine perfusion and what we have seen there and what's going on in this field. Just because we changed the allocation and I'm the second speaker, just a short overview. Of course, we have different surgical sites where the cancer recurs, and not only sites, also times, different treatments, and we will hear about tumor biology and the recipient risk factors later and certain technologies. And often it's not resectable, and only systematic therapy and novel immune therapy may help there. The time is also important, I thought. So we always, when I see what randomized studies are planned at the moment with HCC recurrence and machine perfusion, I'm sometimes worried that we will have a meaningful answer if we have a follow-up of only a year, because many cancers recur later, of course, and we need to look into that outcome, of course, at later time points. We have early and late recurrence. You see, that's just one example. There's multiple papers on this. So mechanism. This is something more generic for various cancer types, and it's also linked to what happens before transplant. Why do cancers spread? Why do they settle and hide in certain microvascular environment and wait for an immune system to be compromised, as we see sometimes after major liver resections with a little bit small size syndrome, when the metastases recur very early in the liver because the patient is so long in hospital and compromised for a long time. And of course, this is described in various articles. This is just an example here. And you can see that many factors contribute. I just want to focus on one or a few important things, which is, we already spoke about systemic inflammation in, for example, NASH patients or in patients with ongoing inflammation through viruses in the liver, which cause the development of a cancer in a cirrhosis. But it's the same in the whole body, and it's the same after transplantation. And an impaired innate immune system, of course, also contributes significantly to the extravasation of those cells. They connect and conglomerate with the immune cells like neutrophils, build clusters, and then they can hide, they can extravasate again and infiltrate other tissues and hide there and wait for the time to recur. And there's various factors promoting cancer recurrence after surgery in general. This is an example of breast cancer, but you can do it one-to-one for liver surgery. And you see there's many factors here, like the anesthesia, the circulatory system with the reperfusion injury and the post-reperfusion syndrome causing and the need for transfusions, for example, coagulation problems, anesthesia, medical management, the immune system, and again, the inflammation with all those cytokines where I always believe we only know a few of them which are released. So mitochondria are, of course, interesting. You know, I'm very interested in underlying mechanisms there. And it's a fine balance to understand what is too much cellular stress and what is needed for all these molecules to defend reperfusion injury and the stress, and what is too much oxidative stress, which leads to irreversible injury, as you see here, and an ongoing inflammation, which is basically the problem, the non-resilient inflammation in the tissue. And we all know that ischemia triggers certain key events. This is all published for many decades in high impact journals. And we know that it's ubiquitous for all organs. Here you see heart, liver, brain, kidney. And you see that this succinate is one trigger of that injury. And the respiration is, of course, on hold and you lose the energy. So that's the key underlying mechanism why machine perfusion could change something. And when we then reperfuse, we all know that it can get really rocky and we can see a high burst of inflammation. And when that is not resolved in a reasonable time, together with immune suppression and other treatments, we promote and we prone the tissue for cancer recurrence. And there's a lot of downstream effects. And here you see three of the main first downstream results. So if you have the radical release after a reperfusion, you get these cytokines and they change the microenvironment and make it more favorable for engraftment of circulating tumor cells, which may be circulating more to manipulation or to other systemic factors we need to assess more. And then you have, of course, the link and the communication with the immune system and neutrophils T cells, which play an important role where we have to understand more how those checkpoint inhibitors can help further, again, between tumor recurrence and rejection. But they affect clearly the tumor cell motility and how they can resettle and how they can swim in the bloodstream and evade into the tissues, which are also inflamed. Because you need to understand, when I transplant a liver, the inflammatory cytokines, they go certainly to the lung, they go to other organs immediately, very quickly. And if you have a high inflammation triggered by a big liver, for example, fatty liver, maybe with long ischemia, you have more of this. And that's the mechanism, or some of the mechanism, why we see those recurrences in lungs, for example. It's not well explored, but that's part of it. And here the example of bone, this is the same. An interesting review, already 10 years old, but still highly actual. And you see it's the same. It's a microvascular environment. The cells can distribute extra weight and enter the bone, which is often seen in HCCs. And there's also mechanistical papers showing that those different HMGB1, DAMPs, other molecules, caspase-1 cascades, and toll-like receptors, which all contribute in the end to how quick and how effective those cells can resettle and how they can hide from the immune system in the future. We heard a little bit about those contributing factors, and when we not talk about the recipient, because it's of course the main contributor too in the tumor biology, there's loads of other factors. Not only the surgical technique, there's a new publication on that, the transplant surgery duration, the transfusions, the medical management, and of course, all the other risk factors we talk here. Living donors have a different risk profile, and I have a few slides at the end. This is a new paper from Italy with European centers, 16, and a large cohort, showing that even the manipulation and the hepatectomy technique may have an impact. And to me, that sounds logical, which is also, again, probably closely linked to biological tumor factors and time and reperfusion injury on the whole concept, what happens during this long surgery. If we now look at the clinical studies, there's not so many with cold storage and looking at HCC recurrence and donor graft risk factors. It's a busy slide. We don't need to look into the details. There's large cohort data from the US, there's European data, there's multi-centered data from different countries. In the end, some papers say DCDs have a higher risk, others say no. Some say donor age is a risk factor, others say no. Overall, it's accumulation, and you have, of course, very good DCDs, which are metabolically very favorable. They will not lead to more recurrence. But this is not the usual cause. DCDs in Italy certainly much higher risk than other countries, and without machine perfusion will definitely lead to more recurrence, or very likely in most cases. So the factors, donor age, DCDs, or warm ischemia and cold ischemia, are those most presented and suggested in those current papers. This is our own data, and we saw the similar factors here in Cleveland. You have living donor DBD DCDs, and you see that with DCDs, particularly when they are outside Milan, so the recipient outside Milan, you see more recurrence, and DCDs and ischemia time was significant in the multivariate analysis. So a little bit in line with the other literature, what we would expect from a common sense clinically. So is it now really a good idea to give DCDs to these extended or even extended HCC patients or even extended DCD livers? We have to, because we still have a lot of patients who have no access to a transplant, and we are also very interested to transplant other tumor entities more and more and to get more livers transplantable. So we need machine perfusion. We need to change something. And this is basically only happening here. So we can either say no to a donor or fine, then we don't do anything, or we change something. So we reduce the ischemia time. This could be with ischemia-free or upfront perfusion, for example, or these things, or we change something before implantation, reducing the succinate load. And this is what's happening, for example, in cold perfusion. And I show you the mechanism. So we have certain techniques. You see a few examples here: machine perfusion, a DCD liver with steatosis and fibrosis. Was it one we did in Zurich a while ago? This is a normothermic case. And there's articles, and you see this is a liver that we transplanted last year with significant steatosis, but we have chosen an HCC recipient with 6 cancers outside Milan, outside UCSF, and we had to do it. He's a year after tumor-free, but we don't know where we go. So we need more data. Mechanism is clear. Mitochondria improve by HOPE. So we reduce the succinate load. We prepare the cells for reperfusion injuries. We reduce this inflammation. This is now measured and shown by many, and now recently also in the heart and in other organs. So we have less injury. But is that enough? We don't know. So we need better data. Mechanism, this is just one example where we can look into all those things in mitochondrial complex. You can compare NRP versus HOPE. This is our animal model. And you can clearly see that cold perfusion improves complex 1 function and reduces the inflammation. So overall, and we all know the evidence for cold perfusion, I'm not going into detail. It is our task to assess what does this do with HCC recurrence. And there's one study from Zurich and there's one study from Italy, and they are, again, the same controversial. This was our study we did with the team from the UK a while ago. We had these extended DCDs from Zurich, which were often also outside Milan and metro ticket in the recipient, and we had better outcomes in terms of recurrence compared to the DBD cohort, while the Birmingham cohort was a control in terms of overall recurrence. So we can achieve a higher recipient risk as well. And this is similar to the paper from Italy. You've seen that here. The team from Turin has shown that they didn't see a difference in recurrence, but also the numbers after 2-3 years get smaller, like in every center. This is standard, but they could use more extended grafts, and they have also more downstaging and more SBRT in the HOPE group. So it's equally safe to use higher risk organs with machine perfusion in terms of cancer recurrence. All this is retrospective, and there's these 3 randomized studies now ongoing. One is from Bologna, one in Modena, and one is a multicenter from Switzerland. Between 40 and 220 cases will be included. And you see the follow-up is very different, up to 5 years and 2 years. And we will need these data to understand what can we achieve and how far can we push the boundaries with these risk constellations. The other technique that showed for recurrence, reduced recurrence, is ischemia-free liver transplant for now. So upfront normothermic perfusion without cold flush using a modified liver assist device in China. All these data come from China for now. And they've seen, as you can see in that paper from 2021, that they have a better recurrence-free survival in both overall and in the propensity matched cohort, as you see here by the graphs. And this is only part of the mechanism. So intraoperative factors we've seen reperfusion injury, of course, with all this microenvironment, tumor recurrence, but there's also another component, which is the liver regeneration. This is part in the resection side, but also for colorectal liver mets, and is also important for living donors. So the lack of ATP is a big driver of impaired regeneration. So theoretically, a better preservation with more energy, not only with hope, but also with metabolically favorable organs will improve that as well. And this is one of the reviews on that mechanism. There's a lot in the animals, not much in humans. And the data also on cancer recurrence recently published with my colleagues from Korea. And you can see that when you have a certain graft size, of course, we know that you have more recurrence and an impaired survival. We just don't know how the other factors contribute. There's also steatosis, some papers from Nancy Kwan Man and the team from Chennai is currently looking at hope in small size grafts and if they can reduce recurrence in that context and also in general reduce the effects of small size and improve growth. There's bloody not much. So we see that this inflammation has an impact also on inflammatory bowel diseases like PSC and also in PBC, but for the not aware of any, maybe you know any relevant publication showing the graft risk, but we may get some data in the future, and METS is very young, but we need data there too to be able to use those grafts for other cancers too. So I'd like to conclude fusion contributes. We know that longer ischemia times are risk factors, and there's currently 3 RCTs ongoing with the machine perfusion, cold perfusion for now, but comparison trials will be started as well. For those many confounders, not only in the recipient side, because the recipient is always very relevant, and to assess all these confounders, we need big cohorts and comparison cohorts with real-world data, future treatments or preparation of the graft for cancer recurrence to avoid it or to reduce it might be interesting during perfusion. And again, the impact in other types and cancers and mets need to be assessed. And I'd like to thank you for the attention and for having me. And thanks for changing the contribution. Thanks a lot.
Thanks, Andrea. Really fantastic presentation. As expected, we really enjoy the pathophysiological mechanisms. While Giuliano is thinking to a potential question and the other, attendee for, any intervention. Let me ask you, speaking again about pathophysiology here, there is also an interesting link between, ischemia reperfusion injury, quality of the graft, and the risk of rejection post-transplantation. I know the connection is not good. We lost you for a while sometime. Can you hear me now? Can you hear me, Andreas? Yeah. Can you hear me?
If you can hear me.
Yeah, a little bit, scattered, not continuously. The question is whether the link between inflammation after ischemia reperfusion injury and rejection may in turn lead to an increase of immunosuppression, then may influence the recurrence of the tumor at the end of the day. So this cascade may be another way to interpret how there is an important impact of the quality of the graft, and in turns the potential benefit of using machine perfusion in that particular setting.
I think you're right. This definitely of these highly reperfusion injured grafts with high bilirubin, delayed recovery, you have to give a certain level of immune suppression to get out of that, to make the T cell less inflamed and release that injury. And that has an impact, of course. Initially, you'll need to give higher levels, what we don't want, of course. And I think this is a very good point.
Thank you, Andreas. Giuliano, I know the connection
Yeah,
is
yeah, I
perfect.
am. No, I am glad that Andrea did really a very good job, and she mentioned the reperfusion, this is the warm ischemia, and I think the surgeon has that in his hand. So, what do you think would be, the longest time you would accept for warm ischemia from a surgeon?
That's a good question. We can talk another hour about viability.
Okay.
Some organs can handle very long warm ischemia time for some reasons we don't know. They can recover, and we need better tools to assess. We use now these FMN, the mitochondrial injury marker, in all normothermic cases based on FMN. We decide every morning, today as well, every morning. And no, not really matter too much about warm ischemia anymore, age, perfusion duration, anything. But you're right. And that's another thing. We need then have livers we can use. We can be reassured that it's safe.